Okay, guys, you're back in the main room now. So what did you think about those films? No thoughts? Yeah. Yes, I think you will need some time to digest them, and yes, they are tiring. And this is one of the reasons that I decided to bring the mature neoplasms a lot further forward than in previous years, so that you actually do have a little bit more time to think about them, particularly about that progression of the myeloid series, and also to practice having a look at the film. So I'll try and have some of these films in each of the upcoming weeks if we can, if we've got time. But you can always go back and have a look yourselves, because remember, they're in echo. So you can always go back. And I strongly suggest that you do that you actually go back and have a look at the films and practice doing the diffs. That pathology student explanation of the different maturation stages of the myeloid line is really lovely. So I do suggest that you have a look at that as well. So 4.11, so that was the, no, sorry, the one beforehand, 5.1. So that's the, as soon as you see that really high white cell count and that diff of the more mature cell lines, so past the promyelocyte stage, you then start thinking about it being a chronic myeloid leukemia. We talked before about the fact that we have to differentiate it from a leukemoid reaction. Can anybody remember how we do that without a bone marrow? What's the old-fashioned way that we don't use very often these days? Yep, so using leukocyte alkaline phosphatase. And what would you expect, Amanda? Can you remember? Sure. Yep. So CML is decreased. So do you know why the leukocyte alkaline phosphatase is increased in a leukemoid reaction? Can you think what might be happening there that's increasing that particular enzyme? Where do we see a leukemoid reaction? What's it in response to? Yeah, so toxic changes, more the fact that just that the neutrophils are being activated and they're actually doing stuff, they're actively fighting the bacteria. They're out there and doing what they're meant to do. So, the granules within in their cytoplasm, so in their, I'm just trying to think of the term for them, it's gone out of my brain. So they are, they're upregulated, they've got lots of them there. So the lysosomes, that's what I'm thinking of. So, they're upregulated and they're using them. So we've got an increased leukocyte alkaline phosphatase. In CML, we've got lots of cells there, but they're defective. They're not able to do, they're not able to function normally. And so that's why we have the reduced leukocyte alkaline phosphatase. Okay, so again, because this is a mature hematopoietic neoplasm, then immunophenotyping isn't really of any use to us, because we know that they're myeloid cells. We know that they're the granulocytes, so we don't really need the immunophenotyping. So this is where we rely on our cytogenetics and our molecular testing. And somebody who hasn't replied yet perhaps can tell me what we are going to be testing for. If we think we've got CML, what are we going to be testing for? Yes, the Philadelphia chromosome. And what is the actual mutation that we are looking for when we're testing for the Philadelphia chromosome? Yep, so we have a translocation between chromosomes 9 and 22, and what is the name that we give to that abnormal gene that is produced? Beautiful. I was going to say, I think Sophia told us before. Okay, so we can detect this gene, the BCR-ABL1 gene, but we can also detect the fusion protein of the same name. So cytogenetics can detect this gene, but we can also use molecular analysis to detect the protein that, as I said, has the same name. Excellent, and that will tell us that we have CML, because again, we do need to differentiate CML from the other myeloproliferative neoplasms, as well as from a leukemoid reaction. And so we can see here that we have that thrombocytosis, and we do often see a thrombocytosis in CML because, of course, they are myeloid cells themselves, but we tend to see an anemia. We don't get that increase in the red cells, which is how we can differentiate it from polycythemia vera. Okay, so anybody got any questions about that case before we go on to the final case? Okay, I'm guessing not. So the final case is in fact a myelodysplastic syndrome, and Deepa, that was well done. That because the analyzer had actually made a mistake with looking at those as counting the agranular neutrophils as monocytes, we may very well go back and reclassify those cells, or we would just make a note of it on the blood film report that the perceived monocytosis is actually due to granulocytes. And as I said, that is actually a dysplasia that we're seeing there. And along with the fact that we have got 2 cytopenias, that's telling us that we have a myelodysplastic syndrome that we would have to investigate further. So when we had a look at the red cells, what did you see when you looked on the blood film with these? Yep, so yeah, there are a few stomatocytes there, but I think overall the red cells were large, yes, and there was it's interesting to say 3+ poikilocytosis Deepa. That's a lot of poikilocytosis. Was there anything in particular that you saw, or did you just think that there were lots of different shapes? Okay, lots of different shapes. I must admit, when I had a look at it, I didn't think there were that many different shapes. There was quite a bit of anisocytosis, and I think there was a little bit of hypochromia there as well. I don't think there was enough there to call this a dimorphic blood film, but there was definitely some hypochromia in some of the cells, but that could also have been, okay, so spherocytes and dacryocytes, yeah. Yeah, I agree with the spherocytes. I don't know that I saw that many dacryocytes. So remember that when you're looking at your at the significance of your the changes that you're seeing, that you've got this grading table. So this is, I don't know if you can see this. You've got this grading table that you have electronically. So I suggest that you download that grading table and have it with you at all times, because it gives you an indication of what a 1+ is, what a 2+ is. And it does depend on what you're looking at. Sometimes it's 1 or 2% will give you a 2+. Sometimes you need 20% to give you a 2+. And so it's a really good idea to have that handy. So really the main thing with the red cells was the macrocytosis and the fact that we had an anemia there. The most outstanding feature was the white cell count with the agranular granulocytes. So we had a leukocytosis with agranular granulocytes, and we also had a thrombocytopenia. Now, according to my notes, there was platelet and nosocytosis there, which there certainly was, and giant platelets. I was not convinced by the giant platelets, particularly not in the part of the film that Melina had videoed for us. There was certainly a nosocytosis there, though. And so when you're summarising this, you would say something along the lines of a moderate macrocytic anemia with leukocytosis and agranular neutrophils and thrombocytopenia. So you would have to consider causes of macrocytic anemia. So it would be, your provisional diagnosis would be macrocytic anemia, query MDS. And the reason you're querying the MDS is because you've got those two cytopenias there with those abnormal white cells. Okay, so remember, when we're looking at myelodysplastic syndromes, they usually present with at least one cytopenia, if not two, and then you can have those abnormalities, those dysplasias within the cell lines. So what further differentiating tests do you think we would need here before we do a bone marrow? So we need our differentiating tests that are going to differentiate our macrocytic anemias. So probably the first thing I would do, Z, would be liver function tests to discount any sort of liver disease, because an MCV of 110 is still fairly, a bit on the low side. So I'd do LFTs as a start, and I would also check the patient history to make sure that they didn't have any sort of inflammatory condition or infection that might be increasing that white cell count. And then I would look at doing vitamin B12 and folic acid. So, they're a little bit further down the list, because again, that MCV is still not huge, but you still would do it just to discount a megaloblastic anemia. And then once you have discounted those things, that would be when you would then go and have a look and do a bone marrow. And what do you think you might find in the bone marrow that we're not seeing in the blood film? I'm getting lots of people saying ring sideroblasts. So remember that there's only a couple of classifications of MDS that have ring sideroblasts in them. And there are far more that have the unilineage and multilineage dysplasia. But the hallmark of MDS is the fact that we see cytopenias in the peripheral blood, but we see a hypercellular bone marrow. Okay, yes, it's hypercellularity that we see in the bone marrow, and it is the fact that we have dyshemopoiesis here, that we've got, remember, we get those unbalanced cytogenetic changes, which mean that the cells do not survive. So we have a hypercellular bone marrow, but the cells don't make it out of the bone marrow because they're too abnormal with their unbalanced chromosomes to make it out of the bone marrow. They're destroyed before they make it. So that's the main thing there. And then you would do some cytogenetics to see if you could see if there were any abnormalities there. Remember, it's quite common to get cytogenetic abnormalities. Sometimes they can be quite complex. Other times they can be very straightforward, such as a monosomy 7 or monosomy 5 or a trisomy 8. So has anybody got any questions about that case study? Because I'm aware that we've run out of time. So if people haven't got any more questions, I'll thank you for your attendance, and I was most impressed to see the number of students who are attending the prac today. That's fantastic. Thank you very much. I think it's really, really important from here on in that you do attend the pracs to properly prepare yourselves for the exams at the end of the semester. Okay, so I might stop the recording now and say goodbye to you all until next week. Thank you very much again.